Hi, I'm Candy Hilton. I'm the house manager at Grace House Akron. Today we are going to be covering Chapter 9 or Module 9 of the Caregiver Certification Training. The topic of discussion is care at the end of life. So just to introduce this topic a little bit, we're just keeping in mind that once it's determined that a patient is dying, providing comfort care helps in allowing the patients to have a peaceful end. This includes their emotional support, listening to family members, anticipating the loss of their loved one. Care should be individualized to the person's needs and goals at that point in time. Allow them to control as much of their immediate surroundings as possible. So because they already, the person that is terminally ill feels the sense of loss of control, they don't have control over their condition, allowing them to control as much of what's around them as possible will help in these instances. So some things to keep in mind when we're dealing with the very end of life. Making sure that the environment is comfortable for the person, and that may look different per person. It may not be the same. Being attentive and compassionate to the patient and their family members. Avoid burdensome care such as unnecessary weights or vital signs. We don't really do that here anyways. The only time that weights or vital signs are really done is if the hospice nurse is coming in and feels the need to do that. They typically will check blood pressure, temperature, and their respirations and heart rate when they come each visit, even if the person is actively dying. But to do weights, that's very, very, very rare. Respecting the patient and family beliefs, even if you may not agree or it's different than what you would believe with those things. And don't impose your personal beliefs. That can be hard sometimes because it's such a fine line, but just keeping it where you're really focusing on the patient and family and what their beliefs are surrounding death and dying. So patient and family goals related to the dying process. Some things to keep in mind that we would almost say these are questions that the resident and or family members would maybe ask of themselves. Who do you want to be near you? And this is in the case of keeping their actual death experience in mind. Who would they want to be near them? What are your most important needs? Do you have any important goals, like things that you want to do before you get to a point where you're not able to cognitively or physically? Where do you want to die? Prioritize care according to the patient's goals first, and that's for us to know. So once we have the answers to these questions, we are able to better know how to care for that individual. Then the family's goals. So you want to make sure you're prioritizing the residents' goals first, then their family members' goals. Remember to inform other team members if a patient expresses a particular need or goal. So since I've been house manager here at Grace House, there have been several residents that wanted to do certain things on their bucket list, for instance. There was one resident that wanted to see a horse, but they were able to get a miniature horse to come through another organization, and that was a goal for her. There have been some residents, there was one that she wanted to ride the train, and we were trying to set that up, but unfortunately she passed away before we were able to get that in place. But knowing some of those things really can help us to maybe prioritize it, to help them meet those goals. Family members' goals may be something as simple as, can you just call and let us know when they start to really transition and get to the point where they are actively dying, and so that maybe we can be there. Cultural influences. So we did a whole module on the different cultures that we could run into, And this is mostly just a brief overview regarding that. So just keeping in mind like beliefs and values that may affect that person's goals. Respect the need for the resident or patient to die on their own terms. So even though it may not be something that you're used to or that you think may be important, it's important to them. Avoid judging how family members cope with the loss and death. So some family members may show and express that loss differently than others, and it's just a matter of respecting that and not judging it. Other things to consider: who is the patient's family or support system? Do they have any? Many of our residents, they may come here and not have any family or friend support. Basically, the support that they get from our staff and from the hospice agency staff is really the support system that they have at that point. Are there any conflicting goals between the patient and if they do have family involved in their care? Are there any conflicting goals? Continually to reassess what their goals may be, because it could start off when they first admitted that it may be one set of goals, but as they're here, it may change to something different. So just kind of reevaluating and knowing if that has happened. Ask if any discomforting symptoms are being managed well. Always share the patient wishes and or concerns with the whole team. So if you as the caregiver are speaking with a resident and or a family member, and they just through conversation mention something that they would like to do before they get to a point where they can't, just make sure that you notify either myself or Holly or even the resident's nurse from hospice or social worker that may come and visit, so that way everybody's on the same page and we can work to hopefully make sure that goal gets accomplished. As far as the physical environment, I think we do a pretty good job. Our house, for the most part, is really non-disruptive. It's very quiet. But just some things to keep in mind: respect the patient's environment. It might not look like what you think an environment should be as far as their own personal room, but understand that that's maybe how they live. That's what they're accommodated to or acclimated to. And as long as they're going within our rules and policies here and it's not disruptive, then that's what they're used to. So just kind of consider that. Place meaningful objects near the patient or in their line of vision. We had a resident recently that loved the, I think it's Sonic the Hedgehog. He loved the Pikachus. So he had a lot of different stuffed animals of the Pikachus, and that brought him comfort and joy. So they would be right in his view, and then sometimes he wanted them right in the bed with him. Would they like to be near the window? So all of our rooms have access to windows, and you can see outside to the patio courtyard area. But I know there has been times that we've been able to push the bed a little bit closer to the wall so that they have a more of a wide view of the window and looking out of it. Is the lighting too harsh in the room? All of the rooms have dimmer, so it's just a matter of pushing the button to make sure that that lighting is dimmed down. We can turn the lamp light on, so it's just minimal lighting. We have music. It says provide music if that's calming to the patient. There's music channels on our online streaming services on the TV. Decreasing noise in the room if that's bothersome to the patient. We can always close the door if it's too loud from the hallway, but we really try to make sure it's decreased noise like in the front room of the house. Sit down when talking to the patient and or family and really spend time looking at them eye to eye, so it's not like you're in this rush and not really focusing on them. Recognize the importance of your presence. Just being there is what they need sometimes. So it may not be you saying anything, or just really your presence is enough. And it just may be that you are listening and kind of just sitting there. We had a resident a while ago that was 102 years old that we just loved, and sometimes it was just a matter of someone just sitting in the room. She would sometimes say, "Don't go, stay." So it just was that comfort for her to know that somebody was there. Symptom management related to decline in status. And this is kind of an overview or summary review of what we've already gone through in some of the other modules. Agitation, restlessness. So the residents may make restless or repetitive motions like pulling at their clothes or sheets. Observe if they have a full bladder, if they have pain, increased pain, or if they may be constipated. So basically, like Cindy always says, have they peed, have they pooped, or are they in pain? The 3 Ps. Require, if they need medication to help with any of these symptoms, maybe they need a Foley catheter placed, because when they get to that point, they may not be able to eliminate their bladder as much. So, and then maybe it could be related to emotional or spiritual distress. So that has shown up with some of our residents from their background. There may be things that they've dealt with in their life that is now presenting as they are coming to an end, and they really haven't had closure on some things. What you can do. So as the caregiver, things to think about: you speaking quietly, repositioning them for comfort, playing the music, maybe decreasing the number of people that are in the room, avoiding asking too many questions. It says, doing a light massage to the forehead, back, or arms if the patient tolerates it. It may be something just as simple as putting a smooth, like a cool cloth over their forehead, wiping their face off, just something that could help make them feel better in that moment. Observe what actions increase or decrease the agitation and adjust that accordingly. So maybe it is too much noise, even if it's not allowed from the front part of the house. Maybe just keeping their door closed so it's not as loud. And then making sure that we're aware, that we can let the hospice nurse know. So pain is another symptom. You can observe that by moaning or grimacing of the face that the resident may have if they can't verbalize that. Massage or repositioning may be helpful. Repositioning, I would say, is probably key. And sometimes if it's a resident that may have pain when you do reposition, maybe think about either medicating them a little bit before you go to do the repositioning, so that way they're not in as much pain. Notify a nurse if it's myself or Holly on call, if it's after hours, or if it's during the day, notifying me. We can always reach out to the hospice that they're on service with. If they're reporting pain or you're seeing the observations of pain and it seems to be increased. Dyspnea or difficulty breathing, shortness of breath. Make sure the head of the bed is up. You can reposition the patient. Sometimes they slide down in the bed, so getting them pulled back up, put the head of the bed up. We have little fans that we can use, that we can turn on. There's also a ceiling fan that we can turn on in each room, and that can help bring in that air for them so that they're not feeling so short of breath. You want to instruct them to take slow, deep breaths, or use the pursed lip breathing, where I always would say, act like you're smelling a flower. They may not be able to follow those instructions, but they may have oxygen in their room. So if that's in their room and they can use it, you can always apply that if they haven't had to use it up to that point. You can ask the patient if they're able to answer what maybe has helped them in the past when they get like that. And then if there are medications ordered, such as Ativan or any breathing treatments, those things may help as well to help those symptoms of shortness of breath. If there's noisy respirations, which We do typically see that with a lot of our residents as they get to the point of actively dying. This is the pooling of secretions because the throat muscles are not as strong and more relaxed. And this can be really disturbing for people to hear, especially family members. So repositioning the resident helps. Try not to use the term death rattle, even though that's what most family members, they oh, this is the death rattle. So they're familiar and they may use that term. But just providing support to the family when that happens and let them know if they have medications that can be administered for those respirations or secretions. There's Levsin that most of the hospices will use and order. That can always be given, and that will help to decrease it. It may not take it away completely, but to help decrease those secretions. We don't do any suctioning here, not that that really helps anyways, because usually it's so deep down that you can't really get to it anyways. But if there happens to be secretions in the mouth, we can always take some of the mouth swabs and kind of get some of that out. Anorexia and dysphagia is other common symptoms at the end of life. So the anorexia basically is lack of appetite. We see that very, very commonly with our residents, that slowly but surely their appetite starts to decrease. Dysphagia, we'll see that when they really get to that actively dying stage where it's just difficult for them to swallow. They may not be able to suck through a straw anymore. And at that point, we know it's probably the next step is that they'll not be able to swallow pills. So our caregivers, and you're quite aware that you crush the pills that can be crushed, and we slurry it. So we just add a little bit of water and put it in an oral syringe, and then just put it in the under the tongue or on the side of the mouth to help them swallow or for it to be absorbed. This happens when the body starts to shut down. If they're still able to, you can offer small frequent sips of fluids or bites of food that they may be able to take that. A lot of times when they get to this point, they're not really taking anything to eat or drink. And at that point, we do use either the lemon glycerin swabs or just the plain mouth swabs and dip it in water. And that way we can moisturize their mouth regularly. And if we're not doing that every hour, I would say every time they're repositioned, we're making sure we do mouth care. Do not continue doing any of this if they start to cough or choke, and report that immediately as the caregiver. Provide frequent mouth care for the ones that are unresponsive, like I was saying. Just general comfort care, which most of you already do all of this. Lubricating the lips, we have chapstick, and if the hospice has like lip moisturizers that can be used, especially if they're on oxygen and wearing oxygen. We don't want to use any petroleum-based like lip therapy. Swab the mouth. Don't insert dentures if the mouth is sore. We can provide ice chips, small amounts of fluid if they can still swallow. We don't use a draw sheet, but we have the bed pads, and that takes the place of the draw sheet, so it's still used in that same manner. So make sure you're using that, which all of you typically do. The pads we can use, we have the disposable pads and the adult, I call them briefs, but that can also be used. Apply moisture barrier to the skin. Most of the hospices order that. When the time comes for the indwelling catheter, the Foley catheter, that can be placed. Watch for bony prominences. So we just try to make sure that they're repositioned so those areas, because they are higher risk for getting like skin breakdown. The repositioning frequently, and then medicating prior to any procedures. So some things to keep in mind at the end of life for psychosocial and spiritual issues. Allow the patient as much control in their care as possible. and assume that they can hear everything. We always tell family members that's usually the last sense that goes when things start to shut down. Adjust your language. Don't use words like diaper. Instead, use a brief. Some people are like, well, what's a brief? but it's basically, it's got the tabs on the side. Pull-ups are used, but that's usually when they're up and able to ambulate. It's too hard to use the pull-ups in bed when you have to constantly turn and change. Orient the patient frequently. For those who are nonverbal, check to see if they can squeeze a hand or blink to communicate. They may just be staring out in space, what it looks like they're staring out in space. So you just have to kind of use your best judgment at that point. Or if a family member is there, they might be able to help with that. Psychosocial support for the family. Listening to them, always a big thing that you can never go wrong with that. Allow them as much control over the situation as possible, because to an extent the family members are feeling like they can't control anything either. And know who the decision maker is. So usually when we get admissions, we have an idea of who might be a power of attorney for the resident, but a lot of times we get residents that come in that there's no healthcare power of attorney. So at that point, you kind of get a feel of who in the family is the one that's making those decisions. It might be a spouse, it might be a child, it could be anybody, whoever has been in that person's life the most and helping them throughout their illness. Respect the preferences of the family's decision, whether they are with or not with the patient when they pass away. So some fears that may come up with some family members, they may not feel comfortable being alone with the patient, just because a lot of times family members may not have ever experienced having someone close to them die. So to see this a new experience, and they may not be that familiar. So sometimes it's helpful to maybe even ease their fears by just being there, letting them know if something changes, put the call button on, we'll come right back to the room, or saying, helping them and educating them through some of those stages so that they're more aware of what they could see. They may be afraid that the patient is suffering. How will they know when that person dies? How will they respond once the person dies? Will the patient die if they give too much medicine? That's a huge one. I've had family members think if we give pain medicine like liquid morphine, oh, you're just giving enough so that just hastens their death and makes them die faster. So it becomes a lot of education at that point. So what can you do as the caregiver? Again, educating, so that would be keeping the family informed as to what's going on. Tell them what to expect. This all falls under education. Allowing them to help care for the patient. So if it's things like you're going in to reposition, if they are okay and they want to, allow them to help. Allow them to maybe do simple things like get their blanket pulled up over them, and they can do mouth care. They can swab their mouth out if they feel comfortable with those things. Encourage them to talk to the patient even if they're not verbal anymore. Have them say goodbye. Suggest spiritual support. We have a spiritual advisory board, as well as the chaplains that are on service with whatever hospice they're on service with. So any of those entities could be able to provide that support. And again, not imposing your own beliefs at that point in time. Other issues around dying would be their final rally. Sometimes we always say the calm before the storm, and sometimes there may be a day where that person is like sitting up, talking, eating the most that they've had in like days or weeks. And the family members may think, oh, they're getting better, and but it just may be that what we call a surge of energy that they're having at that point in time before they actually get into that place of being non-responsive. Symbolic language, there may be vision-like experiences. They may have trouble letting go, saying goodbye, or the person dying alone. The thought of them dying alone may be an issue. Signs that death is near. This is hours to days. And we have booklets. I know a lot of the hospices will give booklets as to for the family members to see and for the patient to read so they can kind of know what they may see leading up to death. There may be more sleeping, increased sleeping, decreased consciousness, withdrawal, decreased urine output, dark urine, skin coolness, incontinence, noisy respirations, irregular breathing, the apnea where it may be periods and those periods get longer the closer they get to death, but where they don't breathe in between breaths. Changes in skin modeling or in skin color, which is the modeling where they get that bluish, purplish color in certain areas of their body, mostly like the knees and sometimes their earlobes and feet. So when we look at signs of death, there won't be a heartbeat or respiration, bowel and or bladder incontinence. And you may see this and sometimes you may not, but they'll be unresponsive, eyes slightly open, dilated pupils, they're not reacting to light, jaw relaxed and mouth slightly open. At that point, the caregiver who's on shift for that particular time would just reach out to whoever's on call to notify, as well as the hospice that they're on service with. And then hospice typically notifies the family and the funeral home. How you can support the family if they're here at the time of death. Ask the family if they will know what to do when death occurs, which they don't have to handle anything. Like usually between us and hospice, we kind of handle all that needs to be done there, but we kind of let them know leading up to death that it's impossible to kind of predict. We can kind of guess to say, hey, this is what we're seeing at this time and moment, but we could say hours, days to hours, or weeks, but to say, oh yeah, it's going to happen on this particular day, nobody but God or the higher up knows that. Death is impossible to predict. Family may be shocked because sometimes it happens. You think, oh, this person was talking to me yesterday and then today the person is gone. So it can happen quickly. The hospice nurse is the one that comes and actually pronounces, since they're on hospice services, that person will notify their doctor and the funeral home and the family. The body can stay here until the family can get here, as long as we can't have days, but if it's just a couple hours or so, yes. Encourage family to spend time with the patient so they can say goodbyes. If there's any cultural, religious rituals that they have in place, those things can be done at that time, and supporting them in that. What they can expect with aftercare of the body, and it's just really communicating if the family members are here, what will happen so that they're aware. And then just to reiterate, I know most of you are aware of this, but when we're providing that post-mortem care, handling the body with respect, that's still someone's loved one. And we don't just want to toss them around or what have you. Clean and groom them as appropriate. You clean them up just as if they were still alive. Washing them off, making sure that they look presentable. Ask if the family would like to assist. Sometimes if they're here, they might, but if not, it's okay. And then prepare the family for the body being removed. So just letting them know when the funeral home comes, they're gonna put them on a stretcher, and most times put a blanket over the body so that it's more presentable, especially if there's other people out in the hallways. we do try to close all the residents' doors when we do that, because there's really no, I mean, they have to either go out the front door, the side door, there's rooms right down that hallway. Taking care of yourself. So the reality is, the longer our residents are with us, the more close we get to them. That's just normal. So when there is a death of a resident that's been here for a while, that maybe you kind of grew close to, just making sure that you take care of yourself. That's extremely important. This is part of our job. We see death. We see family members grieving death. Be aware of your own feelings surrounding that. Find out what works for you to help you cope. If it's you talking to other staff members, or you just maybe needing some time when that happens, like, just communicate that. Recognize your limits and ask for help when you need it. Any questions?
I do. You mentioned the vision experiences earlier. Is that like they're saying they're seeing things, or like colors and stuff like that, or?
Usually, in my experience, and Dr. Jones, you can chime in, but in my experience, it's been residents or patients saying, leading up to the phase where they're actively dying, that they may start saying that they're seeing loved ones that maybe have died prior to, and they may call on their mom or dad. If it's an older person, you know that person has been probably deceased for a while. But so that's what my experience has been.
Okay.
Yeah, I've actually had some of our patients here say that they had multiple near-death experiences, and then came back to explain and talk about it. So bright light, some people know bright light, just dark. Some people seeing people they've seen, some people saw God. We've had a patient who had a life-changing experience here, and they were in the ICU before coming here, and their whole life and orientation changed after this sense of being loved and forgiven, and like they were just completely different after that. So I think listening and supporting and learning.
Yeah,
Because
for sure.
we don't know and understand everything ourselves. We're people of science, but we show humility in this area where people are right between, and historically, that's a time when it's good to listen to the patient. They know what they're seeing, what they're feeling, and they don't need me to interpret it.
Yeah.
If that makes sense to you.
Yeah, absolutely.
Yeah. Okay, well, that concludes our discussion for today. This is the last module for this phase.